My name is Daniel Diaz. I'm one of the interns at the internal medicine program here at Kendall Regional Medical Center, Miami, Florida, and I, along with my colleagues and attendings, would like to present this case of acute type A aortic dissection spanning an entire aorta, resulting in renal dysfunction and preoperative lower limb compartment syndrome in a patient with COVID-19. As a brief introduction, acute aortic dissection, or AAD, is a rare life-threatening condition that in 80 to 90% of patients is due to a tear in the intimal layer of the aorta, leading to a dissection plane in the media that propagates antegrade, mostly. Incidence estimated between 3.5 and 4.4 per 100,000 persons in the United States. Risk factors include hypertension, atherosclerosis, known aortic aneurysm, previous cardiac surgery, connective tissue disorders, and cocaine use. AEDs occur twice as often in males, and type A in particular occur more often in individuals seen between the ages of 50 and 60 years. If left untreated, they have a mortality rate of 1% per hour in the first 24 hours before surgery for type A dissections, and risk factors for in-hospital mortality include cardiopulmonary resuscitation, renal dysfunction, and lower extremity ischemia. Our patient was a 54-year-old Hispanic male smoker with a 20-plus pack year history and a past medical history of uncontrolled hypertension, type 2 diabetes mellitus, and current COVID-19 infection, who presented to the emergency department of our institution 30 minutes after symptom onset, complaining of severe tearing chest pain that radiated to his back and an inability to move his right lower extremity. Vital signs showed severe hypertension in the right upper extremity of 203 systolic over 90 diastolic, with a 20-point differential in the left upper extremity. Physical exams showed a pale diaphoretic patient in acute distress with distant heart sound and a cold right lower extremity with the absent dorsalis pedis pulse and a posterior tibial pulse, and a lack of sensation and motor function in the right foot, suggestive of compartment syndrome. Studies done in ED included an EKG, which showed no evidence of STEMI or RCA dissection, and a CTA of the chest and abdomen showed an ascending aortic aneurysm of 4.3 centimeters and a Stanford type A aortic dissection extending from the aortic root with involvement of the aortic arch, as seen here in figure 1, through the thoracic and abdominal aorta, terminating in the left external iliac with occlusion of the right iliac artery due to false lumen thrombosis, as seen here in figure 2. The dissection flaps were also seen extending into the proximal left subclavian artery, as seen here in figure 3, and bilateral renal arteries, as seen here in figure 4. Initial labs done were significant for leukocytosis of 12 and a metabolic acidosis of 7.2, secondary to lactic acidosis of 6.9. Medical management was started in the ED with an esmolol drip and a nitroglycerin drip to control patient's blood pressure, and patient underwent emergent aortic arch repair and aortic valve repair and right lower extremity fasciotomies due to compartment syndrome. Patient also had a prolonged ICU course requiring 14 days of intubation with subsequent tracheostomy tube for 23 days. He also required hemodialysis due to acute kidney injury and anuria, secondary to decreased renal perfusion, IV contrast use, and rhabdomyolysis. During the patient's stay, he also was complicated by an upper GI bleed, secondary to a duodenal ulcer with a visible vessel, and a left chest wall wound with pressure ulceration requiring debridement. This patient had a Stanford type A dissection originating in the ascending aorta and extending to the aortic arch and descending aorta. The case is unique because it represents the involvement of the entire thoracic aorta and abdominal aorta, with multiple complications including lower limb ischemia resulting in compartment syndrome and malperfusion syndrome with bilateral kidney involvement requiring dialysis. AED in the setting of COVID-19 infection has recently been documented in the literature, prompting the need for further exploration of this association. Our case highlights the need for a prompt diagnosis of AED to improve patient survival and reduce morbidity from related complications. Initial management includes controlling the pain and lowering blood pressure with beta blockers to reduce the rate of rise of force of the left ventricle. Treatment for AED is dictated by aortic involvement. Type A AEDs are a risk for aortic rupture and typically require surgical intervention with increased rates of mortality in patients who are only medically managed. Our patient underwent immediate surgical treatment and was able to leave our institution intact for a rehab facility.